Bismillahirrahmanirrahim. Now we are discussing the amniotic fluid disorder, the polyhydramnia and oligohydramnia. First of all, look at what is amniotic fluid. It's a watery fluid which surrounds the fetus in the pregnant mother. Okay, so here you can see also it's surrounding the fetus. If you look at the amniotic fluids, it's mainly water. 99% it's water in the amniotic cavity, and other 1% are other solute glucose, protein, and electrolytes. The other component, but 99% it's water. Before 20 weeks of gestational age, so this fluid is mainly coming through the placenta, where the transudation or via the non-keratinized skin of the fetus. This is coming from mother. Okay, before 20 weeks. After 20 weeks, what is happening after 20 weeks? This is also coming, but the major contributor is the fetal urine. Okay, so it's almost give 500 ml per day. There are two things. One is this is fluid. The baby is swallow it and urinate out. Swallow it. When they swallow it, this decrease the amniotic fluid. When they urinate it, it's increase the amniotic fluid. Okay, so and there are some other active secretion of amniotic epithelium, and the other fetal secretion like lung salivary secretion and the CSF. So this also contribute, but the major contributor is the fetal urine. Okay, so what is composition? As I mentioned, it's a 99% water, and it's a clear fluid and alkaline in nature. Okay, and 1% are solid glucose, protein, electrolytes, and other solutes. Okay, and if you look at the color, the color is clear pale yellow in the early, but later become as opaque due to these cellular changes, Lunogo cell, the discombinated epithelium or vernix. So due to these changes, it's become opaque. Okay. So, and if you look at the average amniotic fluid volume, it's increasing by the gestational age. So, if you look at 12 weeks, it's only 50 ml. At 24, it's become 500 ml, and at 36, it's almost 1000. But after the term, it's again going to decrease. Okay, so at term, usually it's between the, if you look at the borderline, 500 to 1500, but it's average 800 ml. But at the post term, it's 450 or 350 ml. So it's decreasing after the term. Okay. So and what are the functions in the pregnancy? It's help protect from the infection, because it's immunological. It promote the fetal growth, promote better. It's promote the lung development, GAT development, musculoskeletal development, because allow the movement of the limbs and regulate temperature and nutrition. In the labor, it is help the cervix dilation, because it prevent the fetal distress. Okay, because act like a cushion. And the other thing, act as a lubricant and antiseptic fluid after the rupture of membrane, mean after the labor. Okay, in the labor, when the rupture of membrane occur, so it's act as a lubricant and antiseptic fluid. Okay, because it's immunological. So this is normal. So what is happening? As you know, this is going to increase by the until term. After the term, it's going to decrease again. So these are normal values. Amniotic fluid volume is 500 to 1500. So this is borderline. And we also check out the index, amniotic fluid index, which is 5 to 25 centimeters. So these are radiological values, 2 to 8 centimeter for vertical pocket. Okay, so in the polyhydramnia, what is happening? In the polyhydramnia, so this fluid level going to cross the 2000 ml. So then it's considered a polyhydramnia, or when the index is above the 25, or the vertical pocket level is more than 8 centimeter. So this is considered polyhydramnia. In the oligohydramnia, there is a low level of amniotic fluid, less than 500 ml, or index is less than 5 centimeter, or vertical pocket is less than 1 centimeter, then is considered as a oligohydramnia. Okay, so what is normally happening? There is the cycle, 3-year cycle, in which the fetus swallow the amniotic fluid, and which is, you can say, outflow, means it's decreasing the amniotic fluid level. And when he urinate, he or she urinate, and at the lung liquid, so this all increase the amniotic fluid, you know better. So there is a cycle. So when they engulf, so this decrease. So when they urinate, it's increase. So if the baby is unable to swallow it, so this lead to polyhydramnia. And if the baby is unable to urinate, so this lead to oligohydramnia. So renal problem cause the oligohydramnia, and the swallowing problem are, you can say, the esophageal or the GAT tract atresia, especially duodenal atresia, esophageal atresia. So these cause the polyhydramnia. Okay. So first of all, we look at the polyhydramnia. You can see here the high level of amniotic fluid. So these are the level, you know better, more than 2000. So amniotic fluid is considered as the polyhydramnia condition. Okay. So what is the presentation? There is oversized abdomen, and there is a pressure symptom, and there is etiology symptom. What cause the polyhydramnia? Okay. So, for example, if the mother is diabetic, so it means the baby is more urinating. Why? Because the high level of glucose of mother is also going toward the fetus. So this also increase the urine. As the diabetic patient, there is increase the frequency of urine in the diabetic patient. So same thing is happening to the fetus. So they increase the urine. So this lead to polyhydramnia. So this now look at the amniotic fluid index. So we simply divide into 4 quadrants. Okay, so, and then check out the amniotic fluid level the ultrasound. So how you can check out? You can see here you can see different pockets. So you simply calculate the vertical measurement. So go for the vertical measurement, and this define the how much amniotic fluid is present in the amniotic cavity. Okay, so if it's more than 8 main in the vertical pocket, so this is the polyhydramnia condition. Here you can see 10. So this is a polyhydramnia condition. And you can check out this is for the one, and you can check out all 4 quadrants and then add up. So for example, 10 plus 7 is 17, then plus 17, add 9, it's become 26, then 6, 32. So it's more than 25. So this is polyhydramnia condition. So this is the amniotic fluid index. Okay, when you add up all the 4 quadrants, the vertical pocket, deepest pocket. Okay, so but when you the radiologist calculate, they must avoid the fetal part. So only look at when there is only fluid, okay, in the deep pocket. Okay. There are 2 types of polyhydramnia, acute and chronic. So the chronic is the common, while acute is the rare condition, but it's more dangerous as compared to the chronic because it's occur most before the 24 weeks, and mostly due to fetal cause, monozygotic twin, which mostly cause the acute polyhydramnia. While the chronic, it's common, you can see 1 out of 200, while the acute is 1 out of 2000 cases. So it's mostly due to maternal cause, and its occurrence is after the 28 weeks. If you look at symptoms, so as it's acute, so there is a rapid onset. Okay, and the other symptoms are the rapid nausea, vomiting, abdominal pain, dyspnea, palpitation. Okay, and while these are the gradual onset, okay, and there is abdominal discomfort, but there is less pressure symptom as compared to the acute. If you look at general sign, of course, there is a lower limb edema, and there is a weight gain. Okay, because due to polyhydramnia. And if you look at the abdominal sign, so the abdominal sign, that there is an enlarged abdomen, and the fetal part are unfed because there is a rapid onset, and and the fetal heart sound are not heard. So it's a dangerous condition. While in the chronic, so there is the skin is very tense, and the stretch fetal part can be felt, but there is a difficulty to feel it, difficult to hear. But in these here in the acute, it's unfelt. I mean, you cannot felt anyway. But here is if some experienced doctor can can feel it or can hear the fetal heart sound. Okay, and the fundal length is more than the amenorrhea. And if you look at the provisional examination, so there is partially dilated cervix with the bulge membrane. Okay, if you look at the vagina, so there is a partially dilation, some dilation of cervix. Okay, and there is bulging of membrane. How you can manage acute, it's a dangerous condition, so go for the termination. While the chronic, look if it's there is anomaly condition, or there is a or the fetus is mature, then you terminate the pregnancy. Otherwise, if it's immature, wait for the maturation and give the supportive therapy. Okay. As I mentioned, what are the etiology? Etiology is mostly is the idiopathic, means 65% cases are the idiopathic. So, and are the due to decrease in swelling or increase the production of the amniotic fluid. Okay, so are due to uncontrolled diabetes. Uncontrolled diabetes increase the urination of the fetus, which cause the polyhydromnia. And if there is atresia, atresia mean what? Mean the baby cannot swallow the amniotic fluid, so this will increase the amniotic fluid in the amniotic cavity, which lead to polyhydramnia. Okay, or there is encephaly. Encephaly means it's the neurological problem. Okay, and if you look at the investigation, of course, you check out the amniotic fluid volume index and deepest pocket. Okay, what are the complication? There is some maternal complication, of course, due some cause like diabetes mellitus complication, depending upon the etiology. What etiology? So that are associated the complication. Okay, so and there is pressure symptom and sudden rupture of membrane. There is preterm and the placental abruption, cord prolapse, and male presentation, atonic, postpartum hemorrhage. So are the dysfunctional labor. So these are all complication of polyhydramnia. Okay. And if you look at the fetal side, of course, it can cause asphyxia and pulmonary hypoplasia. Okay, and there is a prematurity complication because if the early delivery before the maturity, so this would be a complication. Then you go for the steroid therapy or manage the patient until there is a lung mature or the other organ are mature. What is management? Management, of course, if it's acute, go for the termination, acute rupture of membrane and or vaginal delivery. If it's not feasible, then of course go for the cesarean section. But there is no other way for the acute onset. Okay. In the chronic, if you look at the anomaly, go for the termination. If otherwise, if there is no anomaly, check out the maturity. If the mature fetus, then terminate the pregnancy. And if it's immature fetus, wait up till the 37 weeks, give the patient rest, hydrate the patient, amnio reduction. Okay, you can put the syringe here and remove the amniotic fluid and control the diabetes, the endomethacin, so it's actually decrease the urine production, and the amniocentesis to check out the karyotype if there is a chances of the anomalies or not. Okay, so these are some management steps toward the chronic polyhydramnia. So these are the etiology which cause increase production and which decrease uptake.